Doc, let's get into yung insights nyo. I mean, lesson one, I want to jump to 2 and 3 if you don't mind. But lesson one, as you said, is everything must be science-based. Let's listen to our scientists. But in lesson 2 and 3, it refers specifically to what you've learned about the different kinds of tests. What do we know now with regards to PCR, rapid antibody tests, and so on?
So I think the most glaring lesson that we've learned is that we had the fortunate circumstance of having the two tests available, the PCR and the rapid antibody tests, and we were able to test them side by side in 3,033 patients. So what we found out is that the rapid antibody test only predicts 20% of those who were really positive. So
that low.
Yeah.
That low. That means you're missing out on 80% who would have been positive, and they'll be walking around thinking they're negative. So there is no data anywhere else. That's why we thought we subjected that to statistical analysis, and then we in science we call it a high confidence interval. So we decided to maybe use it as a basis to recommend the non-use or to stop using rapid antibody tests to screen for COVID-19. So
Pero
it's
hindi pa rin
a very complex science of immunology. I don't think it's easy to understand from a businessman standpoint or a policeman standpoint or any other area which is commonly used. So although it still has its use as when we do our convalescent plasma screening, we use it to see if indeed the antibodies have been formed already.
Yes.
But then again, it's not very accurate. Still, the higher technology of ELISA and ECLIA give us a better level. So generally, I think we cannot put too much weight on what the rapid antibody test will tell us on the ground. So
right now, yung protocol, Doc, that the IATF and the DOH recommend is to use it as an initial test. At yung mga magpa-positive doon, yun yung mga EPPCR. So you're saying that that's not even going to work?
Well, as I said, you'll miss out the 80% who So you will not do PCR testing on the 80% who turn out to be negative. We're talking about asymptomatic patients. These are patients walking around without knowing that they have the infection. Some of them. So I don't think that's a recommendation of the DOH. In their latest statement, I think the statements its use is for surveillance. So I think the way I understood the stand of the DOH on the rapid antibody testing.
Pero yun pala ang ginagamit ngayon,
The interpretation of IgM and IgG is more complex than we think, especially if you interpret it together with clinical findings. So I think we should not discount the possibility of missing out some of the findings because we concentrate too much on the test. So it's still important to do symptom screening, which I think even the other doctors are saying might be even more sensitive than a rapid antibody test, screening for symptoms.
So PGH no longer uses the antibody test. Puro na lang kayo yung swab.
As I said, we only use it to screen initially to just have an idea for our convalescent plasma donors. Indeed, some of the antibody tests are reviewed. So as far as PCR is concerned, I think we also have made a statement that maybe mass testing, that the technology and the resources of PCR testing is better, is more rationally used by doing targeted testing. So The problem
Ano
with
ba
the
yun,
mass
Doc?
testing.
Yeah.
I think the extensive guidelines that DOH and PhilHealth have released is quite already leads us to the proper use of it. So it actually eliminates the random. You walk in, you just want to be tested, and we test. It doesn't happen that way. There are certain conditions that tests are done, and it has been divided. It has been categorized for healthcare workers, people exposed to possible exposure to COVID-19 or symptoms related to COVID-19.